Welcome back. Uh, Welcome, listeners and enthusiastic participants. We are into the sixth module of our AI in Healthcare. To take us for today's session, we have Professor Dr. Anurag Agrawal. He is the Dean of Biosciences and Research at Trivedi School at Ashoka University. Prior to that, he was the director at IGIB, and he was also one of the winners in youngest age for the Shanti Swarup Bhatnagar Award in 2014. A enthusiast, academician, trained across the globe, starting from AIMS to Baylor School. We are fortunate to have you here, sir. Welcome. And to take us and moderate this session, we have Dr. Chandra S. Lingisetty, who is the CEO of the Core Care Clinics from US. He did his graduation in the medicine in India, then went on to do the training in UK and US, and then he was trained in Harvard for the hospital management. Over to you, Anurag, sir. And just a small announcement. This is going to be a very big event for all of us because we are attempting Guinness World Record. Welcome, viewers, and over to you, Anurag, sir.
Thank you very much, Suresh. I'll assume you all can hear me. And it's an honor to speak to all of you on behalf of the national boards, and increasingly an honor to see that we are trying to break some record. So I'm going to speak to you as a physician interested in AI on why machine learning in healthcare, but very importantly, when not to use it. I think the biggest challenge for physicians going forward will not be that how to learn to use AI. AI is already in our lives. We are learning day by day. But learning when to use it, when to promote it, and when not to use it is something that our patients will look to us. Our objectives for today are relatively straightforward. We want to build an awareness and understanding of the transformative potential. So we are truly in agreement with a strategy for AI in healthcare for India, SAHI, just launched on the 17th of February this year by the Ministry of Health, that AI has the potential to transform healthcare for India, but while also acknowledging limitations and ethical boundaries that make it very important for doctors to become partners, in fact, leaders in how AI should be used. The most important fundamental of AI in health is they're not equal halves. It is not health for AI, it is AI for health. Health is the better half. Ultimately, the goal, particularly from the strategy, is to improve access, reliability, quality, affordability, equity, and justice in healthcare. From a public health perspective, that is what matters most. And many of our decisions regarding how to use it will be based on this. But then we need everybody to be a participant and a trusted person who wants to use it. Whether you are a patient, a provider, or a payer, insurance companies also need to trust AI. And we need to have a sense of solidarity. It is impossible when you introduce a new technology to be certain that no error will get made. Errors will happen. As long as the errors happen in the pursuit of the above, I think we can all have a sense of solidarity. We are doing it for a larger cause. I'm going to state two somewhat contradictory principles right up front. None of us fully understands AI, and one of the greatest dangers of AI might be that we conclude too early that we understand it. On the other hand, it is okay to have a doubt, but using the doubt to prevent adoption of AI or refuse to use AI is no more rational than just putting on a white coat and pretending to be a doctor. I must say that AI is not new. As far back as 1970, in the New England Journal of Medicine, you see this last line. Computing science will exert its major effects by augmenting and in some cases largely replacing the intellectual functions of the physician. This is Medicine and the Computer, The Promise and Problems of Change. The year is 1970. Even then, you had use cases like this. A program that will help a physician solve a complicated asset-based problem. You have an ABG, you want to understand the patient has a mixture of things. You can have this entire conversation as far back as 1970. Now, what would occur is, if you see the physician has a very tight, small response, if the physician spoke in usual human language, the program would have crashed. Because computers couldn't really talk to us. They could just carry out certain calculations that we provided them the logical framework for. And AI then and AI now are completely different things. Without spending much time, you have to realize that back in the 1950s, 60s, 70s, we were in the beginning of the age of AI, where the idea was you put a lot of inputs onto something and you produce an output. You can learn to classify things, you can get some decision support on complicated things. And each of these looks like a neuron, multiple inputs coming in like dendrites, one thing going out like an axon. And then you realize with more complicated problems like XOR, one of them is not sufficient. You need many of them in layers. Then it starts looking like the brain, because the brain has multiple layers of neurons all linked to each other with few connections between the layers. And that became neural networks. And this period around 1980s, when Geoff Hinton then thinks of an idea, why don't we take the error coming out of the network and feed it back into the system and tell the system you are on your own, figure out a way to minimize my error. This became the real beginning of machine learning, where all you had to do was provide the right answers, a lot of data. The computer would calculate the error for every iteration. It would learn to minimize the error and basically do machine learning to solve things. And I'm going to take the part after this separately. But very basically, then it basically just became a question, what do you feed into the computer system? So for example, if you want to recognize this is a dog, do you feed the entire dog? That's not necessary. All of you listening to me can just see a face picture of a dog and recognize it. I could even blur out most of the dog, just leave the nose, and you might still recognize it. If you were to look at handwriting, you were to look at English letters, I could cover half of it. You could read without any problem. So the point is, we never really see images. We see features in the image. And what is happening on my screen right now is showing you that you want to extract features for machines to get better. So here, for example, we have a C. A C contains two right angles. I have put a kernel. This kernel goes and finds a right angle. Wherever it finds a right angle, the number becomes 3. Where it doesn't and finds a straight line, the answer might be 2. Very soon, this image doesn't look like a C anymore. It is simply broken up into a map of features. These features can be a variety of types, and given enough examples, and that's where the internet was important, millions of examples of images, and that's shown on the right-hand side. Very soon, this thing called convoluted neural networks, where you use neural networks, but you provide them features that is not the actual image, but parts of the image, they became very, very powerful with classifying things. What difference does it make? If you look at a 1993 paper on the use of neural networks to read a mammogram, what you see is human beings put in 43 features. Computer scientists build a 3-layer network. Then they train them on 133 cases. The computer learns to make the classification with only 14 features. But each feature has to be fed in individually by a radiologist looking at the image. After they are fed in, and this curve, for those of you who recognize an AUC, you will see the neural network became better than the attending radiologists. But it was useless, because if the attending radiologist is going to feed in the features and the computer is going to make the diagnosis, the amount of time wasted makes it useless for a doctor in clinical practice. And the 14 features that the neural network would use to come up with the final diagnosis are listed over here. All those of you who read mammograms will see these are very important, but all of you recognize that if you had to say yes, no to all of these, it'll take you more time to simply do this than to just read the mammogram. But with CNNs, humans did not have to feed features. Features were already extracted. Now the machine pretty much builds a model by itself. And very soon, in the world of CNNs, you can not only find the abnormality, you can get a map showing that this is the part that we think is abnormal, and you can get a classification with a high accuracy as per the computer that this is a potentially malignant nodule. And this is the transition that we have gone over the last many years, driven by better compute, better data, and digitalization of the entire world. such that the amount of data floating around is massive. But a huge problem still remained, which was that if you have to label every image, a lot of doctors are required. So, for example, when Google did the diabetic retinopathy, they needed 30,000 diabetic retinopathy images annotated by clinicians. That type of effort is simply not possible, especially in India, where you will never find a good doctor with plenty of available time to sit down and do annotations. This is where something very cool came in AI. This is probably one of the biggest beginnings of the current golden age. It's called generative adversarial networks. All of you, if I were to show you a new diagnosis on a chest x-ray, after seeing 15 cases, you'll understand it. Why? Because you know what a chest x-ray is. You don't need to learn it every time. What do I mean when I say you know an x-ray? You can draw it. I can just give you a blank sheet of paper and you can draw a chest x-ray, and that kind of shows you understand what a chest x-ray is. So what if I had two AIs? One that generates noise and creates an x-ray. That's called generator. Other one is a discriminator. It doesn't have any annotated x-rays, any labeled x-rays, just knows these are all chest x-rays. All the discriminator is supposed to do is look at what the generator is sending and say, is it a real x-ray or not? In this specific case, is it a real echocardiogram or not? And then they go round and round playing with each other until the time the generator can create an x-ray on echocardiogram that looks just like a real echocardiogram, and the discriminator can no longer tell. And you will see how in every round, epoch 1, 2, 3, 4, 5, the echocardiogram starts looking more and more like a real echocardiogram, although there is no patient, no nothing. It's all synthetic, made out of noise. At the point that two are unable to discriminate, you could say the system has an understanding, and using something called transfer learning, now you can give real cases. And today it is entirely possible, only using a few hundred good quality cases, to train machine learning systems that have already been undergone transfer learning. And this has been a big power recently. But this alone was not enough. These are good for narrow applications. But if you want computers to have the power of human knowledge, they need to read our knowledge. And reading is a huge challenge for a computer because it we don't always write things in a way that is intuitive. Now, some people say that Sanskrit is a perfect language, but unfortunately, most of modern medical knowledge is not in Sanskrit. So let's take a sentence. The dog did not cross the road because it was tired. What is it? I could have a second sentence. The dog did not cross the road because it was white. All I've done is I've changed tired to white. And here it is the dog, here it is the road. It is just because of the way we use English. You can see that GPT-4o understands what we are saying, but no previous AI before GPTs would have been able to easily do something like what I have done here. The reason is, the concept is that when you see it and you see the word dog and the road and you see tired, your attention immediately goes to dog because dog and tired go together. In Hindi, a road can be thaki hui, badi thaki si road thi. It could mean bad. But in English, you will never say tired for a road. Similarly, a dog can be white. There's nothing logically saying a dog cannot be white, but a road is much more likely to be white. This particular thing called transformer architectures completely changed machine learning, because after this, attention, where do you go to when a new piece of information comes, became obvious to computers. And after that, they could digest massive amounts of knowledge and build what are called foundation models trained on the sum total of human knowledge, at least the one that is written and documented. Where are we today? This is Articulate Medical Intelligence Explorer, built by Google DeepMind by Vivek Natarajan's group. Here, Amy the patient had conversations with Amy the doctor, and Amy the critic criticized the conversations between Amy the patient and Amy the doctor, until the point that Amy the doctor became good at doing a full conversation for health purposes with patients. To test how good it became, they took 100 OSCEs. All of you know what OSCEs are. Patient actors were used because it would be unethical otherwise. And they tested it in India, Canada, and UK using a set of clinical problems from each of these countries. Now, Amy or a real human physician, shown here as PCP, primary care physician, would interact with the patient actor, not a real patient. At the end of the interaction, it would make a decision, a diagnosis, a judgment, escalate, manage, and then a specialist physician would look at the transcript. It is all text, by the way, although there is a new Amy that can also handle images, and rate them on accuracy, management, and escalation. The patient actor would rate them on confidence in care, perception of openness and honesty, and perception of empathy. This is called a radar plot. The closer you are to the boundary, the better you are. And I think all of you will see it clearly that at least in this specific thing, which is a patient actor, probably describing the typical presentation of a disease, may not be the rare presentation, may not be unusual languages, outperforms a human primary care physician. This was last year. In fact, it was year before last. The paper was published last year, but the preprint from Google DeepMind was out in 2024. And we are well beyond this already in terms of where we are in practical terms today. So let me ask you, well, I'm going to answer it. Is there a need for AI in healthcare? Clearly, healthcare is changing in ways that our health workforce cannot keep up with. Sometimes the volume and variety of information is just so much that we can't keep up. And sometimes the content, for example, if today people can get genome sequenced, they can have variables providing days worth of data at millisecond resolution. It is simply too large or too complex for the human mind to manage. We cannot keep up with the volume, the variety, or the complexity, which means AI will be required, whether we like it or not. Number two, there aren't enough of us. We both need ways that we can train people to be like us and do this faster and better. Yet our medical colleges are lying empty with faculty positions not filled. Same is true for other healthcare workers. And then the number of people on the ground need to figure out a way to work faster, more efficiently, more correctly. And we also need to provide access to healthcare to people who live in areas where doctors and other healthcare workers are simply not there. There are plenty of such places in India, as you all know. What people need from AI depends on who you are. A physician who is using AI, that's physician-facing AI, may simply want to screen for potential emergencies amongst all the routine cases they are seeing. They may want a camera that is looking at a baby that is not moving much in the arms of its mother, in the people sitting outside their clinic and say, this patient is sick, I need to see them first. It might be, a scan with a bleed amongst many scans. We may want AI that simply automates our routine tasks, does measurements in radiology, generate prescriptions from the previous one, generate a discharge summary for us without us having to say anything, assist us in complex tasks. We may want some help in the final diagnosis. We may want it to know the protocol, write complicated chemotherapy prescriptions in cancer. A frontline healthcare worker may have completely different needs. They may simply want referral to further care. They may simply want automation of the filling of their forms that the government requires them to fill. And they might want simple assistance in following the guidelines set out by the Ministry of Health. Patients may need none of this, but may simply want how to manage my illness given a plan that my physician has given to me. They may want information on all the drugs that have been prescribed to them, but nobody bothered to explain to them what these drugs were for. And importantly and dangerously, they may want the AI to help them know, is it time to go see a doctor? And if so, which type? Now, this is a relatively dangerous one, but in no world that I can imagine for the future will patients not use AI for such purposes. We will have to control how they interpret the information that comes, but just like they ask each other, they will ask AI. So what are the clearly right ways of using AI? Wherever AI increases quality, wherever AI increases quality, there are no safety concerns, AI should be used. In areas where there is no alternative, the TINA effect we talk about in India, genomics, public health surveillance, randomized controlled trials are done, or simply nobody else can do it, that's a very good place to use AI. The other area to use AI is where it increases economic or functional efficiency with low risk. A frontline healthcare worker using an AI to screen diabetic retinopathy, there might be some safety concerns of false positives, false negatives. They don't necessarily have the ability to judge whether it's being right or wrong, but still, it is just a referral, right? There is low risk in referring someone to be checked. And obviously, we can put a safeguard that everybody who's symptomatic with a bad vision, even if the healthcare worker screens and finds the answer to be no, it's a normal retina, they still need a referral simply based on symptoms alone. Not difficult to set up the safeguard. On the other hand, if you're doing something irreversible, giving a drug, giving a dangerous drug, you cannot use AI to enable a frontline healthcare worker. You will never see a situation where a thrombolytic can be safely given based on the call of an AI in the hands of a person who does not know how to use these things. Education, training, and testing. This is an area where I think we will see increasing amount of AI. In fact, it is ethical that we learn on virtual cases before we learn on real cases. If we have surgical simulators, it'll be good for us to learn suturing and many other things in virtual simulations as opposed to real human beings. Is there a risk? Yes, there are some risks, but again, safeguards are easy to create. So when you are asked, should you be using AI for a task? This is a good way to look at it. First, is it a narrow and well-defined task? Most narrow tasks, well-defined tasks, you can train an AI to do reasonably well. Is it primarily about pattern recognition, for example, in radiology, rather than a clinical judgment that could be more complicated? If these two are correct, it's an area where AI can often outperform humans. It's an appropriate type of task for the AI to do. But the second thing you must ask is the decision that will be taken based on the AI high stakes or irreversible? If the answer is yes, AI can only assist, never decide. That's the example of thrombolytics I was giving you. And the other thing you have to ask is, what is the worst case harm of a wrong result? Sometimes reassurance can be more dangerous than a false alarm. Sometimes a false alarm can be more dangerous than a reassurance. It all depends on what we are talking about. Then are the technical parts. A physician should ask, was the model trained on data similar to my patients? It has been shown again and again, when AI is used in settings different from where it was trained, it fails. Humans are much more flexible in the way we learn things. AI simply does not have that level of flexibility yet. Number two, you have to ask yourself what may be underrepresented. An AI trained in America is very unlikely to have ever seen filariasis. It may have never seen trachoma. You have to understand that bias hides in small subpopulations. And these are the kind of things you need to understand can be used or not. Then you have to look at the quality of evidence. Has it been tested prospectively? AI is brilliant at retrospective data because the modern AIs, foundation models, have pretty much seen all the data out there. It's only in prospective testing, in real world settings, on patients similar to your patients, that their true performance comes. And then, of course, are the performance metrics clinically meaningful? Don't just use accuracy. You need to know your PPVs, your NPVs. You need to know the rate at which you'll generate false positives, false negatives. What will you do with them? The false positives, false negatives. What will be the outcomes of going wrong? All these things you need to look at from the point of view of evidence. This brings us to safety and validation of AI in healthcare. It has technological aspects and application aspects. On the technological side, you basically are usually thinking in terms of accuracy, but I have to be very careful in this. Validity is the more important thing. Validity is not the same thing. Validity is everything in a health technology assessment. It takes into account safety, it takes into account quality, it takes into account performance on the field, it even extends almost up to effectiveness. If your purpose for using an AI for screening diabetic retinopathy in the field was to reduce preventable blindness, then you have to ask the question, is my tool proven to be valid in reducing preventable diabetic generated blindness in the population? It may be there is no data, but you still have to ask the question. Similarly, if you're looking at an X-ray tuberculosis solution, you have to ask, in the district where this AI solution for tuberculosis on a chest X-ray was deployed, did we find more patients with TB being diagnosed and treated? Did we see a reduction in tuberculosis cases in the years after? Validity is many things. Confusing accuracy with either safety or validity is a mistake many of us make. We read a paper that says very high sensitivity, very high specificity, and we decide that we have already found our answers to safety and validation. And safety is definitely not accuracy. In fact, safety may be higher by compromising on accuracy measures. If the model is not certain, even if it is 75% likely to be correct, compromise accuracy by telling it not to answer. If the type of thing that happens after the answer requires a 95% confidence, you can shift a decision threshold. If you are in doubt regarding a bleed in a person who has undergone trauma, has been stratified, change the threshold that you only say nothing, normal, if it's really definitely normal. You might sacrifice sensitivity to have high specificity. In a different setting, you could do exactly the opposite. You normally in screening for referrals would go for high sensitivity, and that's approach for intracranial bleed. But when you're going for final diagnosis and you're going for a what you would call an irreversible decision, you might go for very high specificity while you observe the patient in different settings. Again, I think doctors are best equipped to do this. Also understand there are two different types of AI, narrow AI and broad AI. Broad AI is the generative AI of transformer architecture that I talked to you about. Narrow AI is very good for specific tasks using well understood approaches. Errors of narrow AI are typically along expected directions. With generative AI, we have a relatively limited understanding of the internal process. It's extremely powerful, but hallucinations continue to be a problem even today. Here is a case. This is a case where there is a head injury. The AI has diagnosed a subdural hematoma. I know most of you cannot see it. I also cannot see it incidentally. But my wife, who's a radiologist, can see it. And it turns out that in this case, the AI is correct, and the doctor confirmed the presence of a subtle subdural hematoma. These are the type of challenges that all of us will face. AI might mark something. I might be an emergency physician, not a radiologist. I might not see the SDH, even after it is marked on this film for me. By the way, it's around here. And because of it, I might be tempted to dismiss the AI. But if I knew that this is a high risk setting, I knew the performance characteristics of this particular AI, I know that it's very accurate with high specificity, and I know that there's something I need to get an opinion on, I will behave the right way when the AI gives me something I don't understand. And sometimes it'll go the opposite direction. There's a patient with shortness of breath. The AI has diagnosed pulmonary embolism. Why pulmonary embolism? You will see that some of the vessels are opaque, contrast is not seen. A doctor who fully understands and has seen multiple pulmonary angiograms will understand the problem is not enough contrast has been given. The ventricles are not sufficiently bright. And if there isn't enough contrast or the timing is wrong, then the vessels will not get opacified. And therefore, it will look like a PE even though it's not a PE. In this specific case, the doctor rejected the AI diagnosis, calling it inadequate opacification. There is, as of now, no substitute to a domain expert for critical decisions with AI. AI is very often right, but frequently enough wrong that doctors need to be in the loop. When you look at generative AI in particular, the biggest problem is that architecture is for coherence, not correctness. Coherence is best defined as what fits well, what word comes next. This is true for vision transformers, this is true for everything. And in absence of something called grounding, external reference, it is impossible for generative AI to not hallucinate at all. The more you can provide external reference and grounding, the less it will hallucinate. But there is always a risk of hallucination. You could input a chest X-ray with a clear pleural effusion. It could suddenly tell you the X-ray is absolutely fine. You could even tell it, look at the costophrenic angles. It will even reply to you that yes, costophrenic angles are a good place to look to find whether there is a pleural effusion. I have looked at the costophrenic angles and there is no blunting. And it can say that when there is clear, no costophrenic angle visible. It is just being coherent on its first statement, the next statement. And this is something that all of you will face if you use generative AI. But still, as I showed you with the Amy example, very often can be very good. It is just not very good with vision right now, but it is particularly good with text interactions, symptoms, and things like this. But still, it goes wrong. How can we reduce this problem? A is today we can create agents. A broad AI agent can have a narrow AI tool. The narrow AI tool can look at chest X-rays and pleural effusions after the broad X-ray knows what it is supposed to be looking for. You can have iterative reasoning. You can go back and forth between multiple agents. And last, I'll not bother to explain this much, something called context persistence, in which you can have a large amount of clinical history accompany the entire thing. You could have, in fact, the entire previous medical records with very long context models. The net result of all this is you get much fewer hallucinations, and error rates today are not very different from a human physician. But when they go wrong, it is very hard to justify to anybody else how could we possibly have missed this. When you think about AI for India, you have to look at AI that will work here, and you have to look at AI that will work here. You have to take advantage of the digital transformation at multiple levels: ABDM, National Health Stack, UPI, UIDI. But you also have to remember there are places like this where there is digital, but there is no use for digital. In places like this, something as simple as voice to digital data, where you no longer have to enter forms, you speak, the AI is already taking care of things for you, might be the most important type of AI. In settings like this, the ICU, you could have complicated algorithms that are continuously monitoring a baby or an adult for any sudden decline with immediate interventions through alarms. It all depends on your use case. Now I come to contentious parts. Who should be using AI in healthcare? The safe view is that anybody who can do the task without the AI is best qualified to do the same task with AI. If you can't do it without AI, don't do it with AI. If that is followed, safety and validation issues are modest because the person who is fully competent is the user. That's true for most doctors using most AIs. But scalability of health services is enhanced only to the extent of efficiency gains of their individual physicians. And if you don't have enough physicians, then clearly that does not solve too much of your problems. Public health value, therefore, with this view is medium. The strategy for AI for health in India is saying innovation over safety, but not to compromise on safety either, but innovate. If safety and validity can be reasonably assured, we can have users doing tasks they could not do without AI. And there's nothing fundamentally wrong in it. When doctors use AI to interpret genomics report, they are already doing things they would not be able to do without AI. It is just a question of thoughtfully percolating this idea further down. What, how, where, when, how it should be overseen are important questions we all need to deliberate. There are no answers that I can certainly provide. But as we operationalize the national strategy for AI in health, these are the things we'll have to think about. There are lots of problems remaining. We have a shortage of data. We need representative data for India. We need extensive testing in the desired use case. In fact, we will never be able to do that many randomized controlled trials. Chest X-ray for tuberculosis that worked in Africa, failed in India, worked in North India, is failing in Northeast India. AI fails unpredictably, and using it at scale is critical. Then there's an expertise gap in everyone, from people who are providers like you, including people who are supposed to be regulators and governance people. Everybody has an expertise gap. And that's what this series by NBME is really about. Then governance needs to be risk-based and benefit-based. If something is high risk and low benefit, just don't do it. If something is high risk but very high benefit, do it carefully. And of course, we don't need to discuss low risk and high benefit. That's obvious. And last, we need to educate the public. Unlike previous medical technologies, this will probably bypass health systems. We need to let people know how to use AI well. We cannot leave it to them. And we need to participate in educating the public on the correct use of AI. So how do I see the way forward? What we are doing is we are working with locally tuned free models. We are trying to build platforms to create places that doctors can engage with, show their preference, see what works for what specialty in which region, and use their feedback to give evidence back to the nation. And of course, we want to use voice as a primary mechanism of health communication, and regional language related layers is V2DD is an important part. All these things need to be regionally scalable, and working with the government is critical in this going forward. Last, I'm going to come back again to the weaknesses of AI. The fact they are very creative now, the generative AI, is their weakness. Respect for autonomy, privacy, and ethics are not algorithm-based. Unbiased collection of biased data does not eliminate bias. Many of us who are researchers will say we collected the data in an unbiased way. Doesn't matter. If the data is fundamentally biased, you are still going to be biased. And last, those of you radiologists will understand this. Activation maps will tell you whether the AI is looking, but doesn't tell you what it is actually seeing. Big difference. It's not really understandability. Let me show you an example of unbiased collection of biased data. America built algorithms to look at who is going to get sicker. And the high score meant you're likely to become sick, so you get extra care. The dark line are black people, the yellow line are white people. The score is on the x-axis. Their medical problems are on the y-axis. What you will see is to get the same score, a black person had to be sicker with more problems. Why? AI is not racist, but black people are poor. Poor people tend to become sicker before taking off from jobs to go seek healthcare. Because they cannot pay, they will often be sicker at the time somebody decides to admit them. AI does not understand human society. It will simply normalize the difference and simply assume that people are equally sick, all initially admitted people. And these are fundamental problems that you can just imagine what will happen in India if we trained AI on the type of data that will be between public hospitals and our private hospitals all mixing together and letting the AI learn. It might decide that our poor people are so strong, they don't need hospitalization at all. Then sometimes we don't know what we want. This is an AI algorithm for allocating livers. The thought probably was to give the liver to the person who has the highest. What occurred very soon is that young people stopped getting livers while old people got the livers. Old people were probably the ones with burnt out liver from alcohol and cirrhosis and things like this, while young people probably had more genetic disease. What is right, what is wrong is very hard to say, but we know that humans, while allocating livers, follow a very different set of principles than simply the risk of dying. A very old person is clearly at a higher risk of death, but at the same time, they're going to remain at a very high risk of death even after they get the liver. There are a variety of ways to address the problem. I'm not going to dive deeply into this, but we need to know what we want the AI to do. It cannot read our minds. And the more we offset decision making to it, the more the problem will be. My final slide, in a sense, the 10 commandments. AI is only for decision support, not decision replacement. Do not deploy AI without local validation. Accuracy is not safety. Rare events will break AI. If you know it's rare, don't use AI. High risk decisions require you to be actively in the loop. Bias in data will become bias in care. Understand where the data is biased. Automation bias, where you become a rubber stamp to what AI says, is a real clinical risk. Explainability matters most when stakes are highest. You don't want a non-explainable black box to decide on whether to give thrombolytics to someone. Governance of AI is as important as everything else. And the very best AI for society will improve health equity and foster trust. These are my key messages to you today. I'm going to stop sharing and hopefully we'll have time for questions and discussion after this. Thank you.
This is wonderful, Dr. Anurag. I think I haven't had a better lesson of late in the machine learning. You made it so easy, starting from how to read the dog space to how AI can hallucinate and everything else. Lot of questions I can see other than some of the background noise and thank you messages in this. Chandra, over to you, and then we will wrap up with a few questions to the public whether they understood or not. Chandra, over to you.
Absolutely. Thank you so much. What a wonderful talk, Dr. Agrawal. That was a very thorough and very thoughtful overview of the entire AI landscape, starting from the basic level machine learning, deep learning, neural network, you name it. You covered everything, including the agentic system. As a clinician, our task, as we all understand right now, is not to understand every technical aspect of the AI, but just understanding where the responsibility lies. Across all platforms of AI, as you all know, the most important distinction is the AI advising us or is it deciding for us? And you know the answer. Now, the interesting part is, interesting part of this session is to look at the questions. Let me just share my screen real quick to bring your attention to a couple of important slides here. So what you're seeing here is a decision support matrix for AI tools. As you review this slide, you may see across all forms of AI, the question is not the capability. The question is how much authority we allow the AI to take over. As you can see in the matrix, this matrix essentially will help us out to decide where we should use AI and where we shouldn't. This is just a mental sort of cue, mental anchor, if you like. So now moving on to the next slide, I have segregated most of the questions into these four important buckets. And these important buckets will really help us to stay grounded to what are the categories and what are the broad categories of questions or categories of concepts that we need to talk about in the next 10 minutes or so. So with that, I will just stop sharing here. And there are several questions as you might have expected. They all fall into the first bucket, where it helps. And you have already covered it elaboratively. And if I made one example, I may add just one example to it. In one of the innovations I led, we use machine learning models applied to self-reported health and lifestyle surveys to estimate population level risk for the chronic diseases, cancer, and lifestyle diseases. The value wasn't the diagnosis, it was enabling payers and providers to prioritize the screening, support early detection, early intervention, and managing those cases. This is a good example of AI supporting prevention and resource allocation, while clinical judgment still lies with the clinicians. So, in your opinion, I would be interested to know your perspective on where you have seen AI adding most value in prevention, early identification, or a population health level. Dr. Agrawal.
I would say the best use case I have seen so far probably remains the chest X-ray screening for tuberculosis that is automated. And I'll give you reasons why this particular one worked while others didn't. AI already now is better than human at detecting an abnormal X-ray. And a normal X-ray has reasonable predictive power for at least excluding significant tuberculosis. And this is something that a doctor does not need to do if half the cases, 60% of the cases that come for an X-ray at volume screening can be disposed of directly by the AI. In fact, in a company called Occipit, they got CE certification in Europe. If they said the X-ray is normal, no human radiologist needs to see them. It also fit well into a national TB program and a national health priority. And even there, only stratified screening was done. So either you had to have symptoms or you needed to be a contact of a person with tuberculosis. So I have to also give credit to the national program for thinking it through. You don't go house to house and doing an X-ray on everyone.
Absolutely.
And because of it, it became a success. In districts where it was deployed, the number of case finding of tuberculosis rose. And while we don't have follow-up data, it's my expectation that in time to come, we will see actually a drop in tuberculosis. Now, that's a great example of something that worked. And in fact, ICMR did a health technology assessment. It actually showed that deploying AI saved money. So it benefited people. It made doctors happier. It did not create extra work for them. Many X-rays are disposed directly, and it saved money to the government. What can be better?
Great, sir.
On other hand, there are areas where these things don't work well as well, and where the incentive structures are wrong, or doctors get fed up. My wife's a radiologist. She has a practice in which scans get labeled with triage. Sometimes there is AI fatigue. Every third scan gets listed with something abnormal. So sometimes it doesn't work. But this is very specific use case. And I think the more specific we make them, the better it is.
That is a wonderful example. And I think,
Chandra, I saw a very interesting question here.
yeah,
When to use decision tree versus machine learning?
Okay. So see, in the original definitions of AI, even a decision tree, good old-fashioned AI, GoFi, was also AI. But it was not machine learning in the sense that you provided all the instructions. The machine didn't learn on its own. Almost anything to do in images is almost always ML. In fact, apart from implementing national guidelines via RAGs, but the top-end chatbot will still be AI. So you can combine decision support of national guidelines along with the AI type interface on the top. The example I showed you from the 1970s was a pure decision support while interpreting ABG. Why did physicians not like it? If you entered even a letter wrong, the system would suddenly throw an error. So I don't think pure decision support alone will ever exist in the future. At the very least, the decision support will be in form of a guideline. The guideline will go into a document and context for an LLM, and there will be a heavy amount of RAG to follow that document. And it will be almost be like decision support, but still it will be AI and machine learning.
wonderful. That's absolutely fascinating. And one other thing I probably may be able to bring to the table is, as you rightly pointed out, machine learning. We use machine learning techniques such as random forest and also decision tree, definitely, and maybe a little bit deeper as well, neural network, to look into stratification of patients in an insurance company. When we sent surveys, and when we also had nurses calling the patients and getting their acute and chronic morbidities and their hospitalization history, use of ER and whatnot. And then we analyzed the models and stratified these patients based on their future risk of hospitalization and their future risk of getting any catastrophic diagnosis or catastrophic conditions. That really helped us as well. So I think one of the questions that is a nice segue into one of those questions, who was one of the doctor is asking, what is the difference between AI and what is the difference between machine learning and the deep learning in AI? And as Dr. Agrawal astutely mentioned, it is ML is part of artificial intelligence. It's like a syndrome. Artificial intelligence encompasses all these technologies, starting from all the way from a simple machine learning and all the way to neural networks and deep fakes and deep learning and whatnot. Very wonderful. And I think it's it's interesting how we are able to use AI in population health, larger, broader interventions in terms of public health. And again, in the chat box, I see an important question related to will AI be useful for preventing and also predicting the pandemics? Will AI be useful to plan for the pandemic management and whatnot? I think that is very, very important. And my answer is yes, as long as the clinical risk is low and you are using AI to triage, you are using AI to summarize and pattern highlightation and risk stratification and workflow support. So very wonderful. Nice segue into.
I can add to that. So genomic surveillance of sewage is an area that is now thought to be critical for pandemic readiness. And in fact, the International Society, the WHO, basically IPSN, Pathogen Surveillance Network, International Pathogen Surveillance Network, has prioritized introducing AI-driven analysis of continuous genomic data from sewage surveillance for detection of new nucleic acid into the system. And that will give an early lead time. I mean, the noise and how many false positives remains to be seen. But in fact, there's a meeting in March in UK exactly on this topic.
Excellent. Second important bucket that definitely brought a lot of noise here and a lot of interest here is where AI becomes dangerous. And I would probably say this, AI could reinvent the medicine or become a patient's nightmare. With that, from your perspective, where do you see the greatest risk with agentic AI in clinical workflows, the technology itself, or the tendency for clinicians to overtrust what it generates? What's your perspective, sir?
My biggest fear of AI is what's going to happen with automation and loss of skills. I mean, already you can see it. I mean, let's take previous examples. These days, I cannot remember any phone number except my wife's. And so basically, if my phone shuts down, the only number I can remember to call is hers. A few years ago, I could remember many. Doctors, as they start increasingly using AI, will start using skills. And this loss of skills is going to be tricky. The other problem is going to be hallucination by AI in a critical situation where adequate safeguards and rails are not built. Somebody, sooner or later, will get used to using AI. They will decide they are fully competent. And I can think of a general medicine doctor, for example, given access to AI tools, will say, why do I need to consult a radiologist? Right? Let me do it myself. And I'll give you an actual example from America. And this one works out for everyone, but it may have failed. Every time a patient comes in for a potential stroke, the scan is automatically read by AI. If the AI thinks it's positive, automatically the neurologist is notified. Radiologist is nowhere in the loop. The neurologist comes, takes a call, and decides. Now, this assumes a neurologist is as good at reading a particular CT or MRI as a radiologist, which may be true, may not be true in different circumstances. Now, the reason it worked is everybody is getting paid. You can bill for the AI reading. The neurologist, even if he comes and says the AI is false positive, they will still bill the patient. Patient will pass this on to the health insurance system. So everybody is happy. But look at the cost of care increases.
Yes.
And so ultimately we all pay. So
Yes, sir.
inefficient systems will come into play that everybody will be temporarily happy with, but down the line, it will create escalating costs of healthcare that we'll all get sucked into. And it's certain that the big giants will be able to figure out how to monetize AI for health.
That's so true, sir. There's a strong demand to display the 10 commandments again, because at least I saw at least 30 different people asking for it. And
Let me do that.
Absolutely. Okay. And if there are no other questions, I just want to thank Dr. Agrawal and Dr. Chandra for taking this session and moderating the best way. And those, yeah, here we have. Thanks, Dr. Anurag, for doing that. So this is the 10 commandments. I hope at least I made at least a couple of hundreds of people happy by just making you do so. So So there will be a few questions which Dr. Anurag is going to just display in the PPT. You can answer them at your convenience. This is not a feedback form. And with those things, we are going to wind today's session. Dr. Anurag, over to you again.
So a few quick questions for you. What best defines foundational models in healthcare AI? I think I gave you the answer to that during my talk. It is something worth remembering. Again, you're supposed to figure out the answers. I'm not going to answer it for you, but I'll give you a few seconds while you look at the 4 choices. Task-specific systems, large-scale models, rule-based algorithms, somebody asked about decision support, and experimental models limited to research environments. Oops, I had the answer. It doesn't matter. The question, an AI model provides a detailed but completely fabricated citation in response to a clinical query. Which type of AI creates this trouble? I think if you remember nothing else, remember this. There is a type of AI that is the smartest when you talk to it. It's also one that is most likely to mislead you from time to time. And we have plenty of such cases. And I think, because I know now I click it, the answer will come as well, but doesn't matter. Let's go fast. This probably is also important. A tool increases I do not know. That's what an abstention rate is, to avoid falsely confident diagnosis. What is the strategy? Is it to increase specificity? Is it to reduce hallucinations? Is it to improve safety by shifting thresholds at a cost of accuracy? Is it to improve training speed, or is it to just replace human beings? With that, I'm going to stop, and you are welcome to do this at your own pace.
Thank you so very much, Dr. Anurag. They're very interesting questions. Thanks, Dr. Chandra, for joining. I know it's midnight in US. And Anurag,
Thank you
I
so
know
much.
very busy. Despite that, thanks for taking your time and then just joining us.
My pleasure.
Over to you, NBMS, for any comments, which I'm missing it from the chat box. Anything I'm missing, or we can just wind up the session?
I think, sir, everything is covered at the time, sir.
Thank you very much.
Thank you, everyone.
Thank you, sir.
Pleasure.
Thank you, everyone.
Bye-bye.
Thank you, Dr. Anurag, sir, for this wonderful session. Thank you, Dr. Chandra, sir, for the moderate the session. Thank you, Dr. Suresh, sir, for the coordinate the session. Thank you, all of you. Thank you so much.
Bye-bye.
Thanks.